Hello, everybody, and welcome to this edition of the Taking Control of Your Diabetes podcast. I am one of your hosts, Dr. Jeremy Pettis, joined as always by my good friend and colleague,
Dr. Steve Edelman.
Hi, Steve. So today we have a very special episode, which is going to be on gestational diabetes. So at the top, we wanted to talk about gestational diabetes as something that people can get during pregnancy. It's different than people that already have type 1 or type 2 and then become pregnant. So we did do an earlier podcast on type 1 diabetes and pregnancy. So if that's of interest to you, make sure to check that out. But for this episode, gestational diabetes is very common. We have a very special guest, Steve, that you've known for a very long time. So if you want to introduce our special guest.
Sure. Well, Thomas Moore is an icon when it comes to diabetes and pregnancy. He has been at UCSD almost 40 years and still very active in an administrative role, but also oversees the high-risk OB clinic and has trained numerous physicians who run that clinic now on a day-to-day basis. And it's been a pleasure to know and work with Tom all of these years. And I get credit for getting Tom into continuous glucose monitoring when he was still having all his patients do finger pricks at home, send them in over the internet or the phone system. I finally said, Tom, you've got to get into it. And you know what? He called the folks at Dexcom. He brought him over, got going, and modernized the system.
Well, leave it to Steve in an introduction of somebody else to talk about himself for about half of it.
That's not right. But that was a big deal.
Well, thanks for being here, Tom.
It was great to be here. And of course, it's transformative to be able to do glucose monitoring in this modern way. It's just wonderful. And it's getting more wonderful as months go by.
Mm-hmm. Yep, you're right.
And I would say, obviously Steve and I both work at UCSD also. And my kind of interaction with Tom has been that, I'll have patients with type 1 diabetes, they get pregnant, they go away for basically 9 months, and you guys monitor them, take care of them, and then they come back, hopefully with a happy and healthy baby. So we're very lucky to have this kind of, unique clinic to specialize in kind of diabetes and pregnancy as part of that. So we wanted to jump right into it again, gestational diabetes. So Tom, tell us how common is gestational diabetes?
Well, it's common and becoming more common, which is worrisome planet-wide. The current estimate is that 8% of pregnant women who deliver their babies have gestational diabetes at the time of birth. That's roughly double that number globally. Because the prevalence of the condition, gestational diabetes, does depend on genes to a large extent. And so there are some ethnic groups in the U.S. Who are more likely to have gestational diabetes, including women of Hispanic origin, African, and Native American origin. Others, Caucasians and others, Asians, they get it too, but it's more common in those. So when we look at globally having roughly twice as many pregnancies complicated with gestational diabetes, it's a big deal. And because it affects the fetus, it's a global problem that we should all worry about.
Well, you just named off all the reasons why we're seeing a lot of type 2 diabetes in this country and who's at risk for it. What about maternal age? How does that make a difference?
That's a great point. And maternal age is an interesting issue because the people who have gestational diabetes at, let's say, a 22 years old person perks up with gestational diabetes, and we ask her, anybody else in your family have overt diabetes? And it's not uncommon at all to hear, yes, my mom has it, or my father, or both have it. And ultimately, the masking of the endocrine problems that happen later in type 2 diabetes happens during the pregnancy. So a fair percentage of women who develop gestational diabetes will have type 2 diabetes later in life.
I see.
So Okay, so people might be listening. Oh man, this sounds very common. How do I know if I have gestational diabetes? We know some of the risk factors. So how is it diagnosed?
Well, the standard diagnosis, first of all, it's done differently in different parts of the world. And every society, European society, the International Society, and the American College of OBGYN all have slightly different. But what we're using in the United States is a two-step test that involves drinking without being fasting. You don't have to prepare. You just go to the lab. They give you 50 grams of glucose. You drink it. An hour later, they draw your blood. And that screening test, if it's high, then you have to go do the real test. And the real test in the United States is a 3-hour, 100-gram glucose tolerance test in which you have to have 2 abnormal values. In the rest of the world, pretty much, they've gone down from that two-stage treatment to a single stage treatment of 75 grams, and you don't have to be fasting, and they do it. And I won't go into the politics and some of the science on why we're still doing 3-hour glucose tolerance tests in the United States, but that's the way we do it.
So everybody gets this screening test, is that right?
Yes.
Okay.
Because you can't really tell who's got it until you find out that the baby is huge and it's fat and it's at risk for stillbirth or birth injury.
Mm-hmm. And then this screening test is done, you said 25, 28 weeks, sometime in that range. 50 grams of glucose, which people hate, right? People talk about the taste of this stuff all the time.
It's like simple syrup you put in my old-fashioned.
Well, I've had type 1 patients that say that's one of the best things about having type 1 is they already knew that they had diabetes, so they didn't have to drink this stuff again.
Yeah.
So they get this 50 grams of glucose, which is like, to put it in context, I don't know, a can of Pepsi and a half, maybe like a 20-ounce, can of Coke or something, that kind of amount of glucose. And you said they tested after 1 hour?
Yes.
And what is normal? What is abnormal for that blood sugar?
The cutoff is 140. And if it's above 140, then you need more testing.
Okay.
And if it's less than 140, then you leave the lab and go home and have a nice dinner.
Yeah. Okay. So you do this screening test, and we talked about, what was normal, what was abnormal. What if somebody is diagnosed? And this is probably, there comes a lot of fear, I'm guessing, with people hearing this, diabetes, oh my gosh, this is something I really don't want. What are the risks that somebody should know about to themselves, to the baby, that unfortunately might come along with this?
Well, that's a great question. And the interesting part about it is that that we don't do this test until 24 to 26 weeks of the pregnancy. So really, the first third of the pregnancy, 2/3 of the pregnancy have already disappeared. The reason it's delayed to that point in protocol is because the thing we're trying to prevent is baby fatness. And baby fatness mostly accumulates in the last third of the pregnancy. So that's why we choose that timing. And further science has shown that detecting people with some glucose abnormalities early in pregnancy and instituting treatment, which we'll probably talk about, instituting treatment doesn't really help in the first 2/3 of the pregnancy. So it's really about helping control the mother's glucose to be able to control the baby's glucose in the last third.
Tom, could you expand a little bit when you say baby fatness?
Yeah, I was going to ask about that too.
What is that? Can explain what that is to our lay listeners. And that relates to the large for gestational age issue too that occurs.
Yeah, that's a commonly kind of misunderstood thing. Is that yes, if there's diabetes involved, the baby is going to be big, and what does big mean? Well, it's interesting because now we have ultrasounds that we use to characterize the baby's size. And, some babies have long legs, some babies have short legs, depending on who their parents are, and so forth. And so we've got a range of normal for legs and heads, and we have a range of normal for abdomens. But what we find is when their mother has poorly controlled glucose, the babies don't get long legs. They don't get big heads. They get fatness around the lower chest and abdomen, so that they are just, it's like almost anybody who's getting too many calories, they tend to put the weight on around the center, and that's what happens to these babies. So their head size is normal, their legs are normal, but the abdomens are big, and there's a couple of things that can go along with that. When you have a great big fat abdomen, it's been shown that these babies have a much higher risk of being fat for the rest of their lives, definitely fat during childhood. And secondly, it can be difficult to get delivered, because the head is the normal size and the head comes out, and sometimes we can't get the rest of the baby out safely because of the fat has blocked the baby into the uterus. So there's a lot of drama that can occur if we don't manage this very carefully.
Well, I think that's important for people to know, because I think kind of, in the lay press, the lay world, when we think about baby health, sometimes we think, well, kind of the heavier the better, right? If you're 10, 11, 12 pounds, that must be like a really healthy baby. But, here we're saying, well, gosh, this is actually a problem with diabetes. It can be problems with the delivery for the mom, problems for the child being born, et cetera. Can you tell us a little bit about why that happens? Why is it if somebody has diabetes or high blood sugars during pregnancy that a baby would gain weight?
Yeah, so it's interesting because the babies depends on the mother for nutrient transfer. So every baby comes with its own placenta. It doesn't belong to the mother, it belongs to the baby. And that placenta is attached to the mother and brings food, water, and oxygen across from the mother's blood circulation into where the baby is. And the food part is an interesting issue because when the mother's blood sugar is high, then that blood sugar is seen and received by the baby. So if you can think about, maybe you stopped off at a drive-in and decided to go with a double dessert on top of your Big Mac or something like that, you know that those calories are going to add up at least temporarily. Well, what happens to the baby is during a maternal eating episode, let's say, and the blood sugars are high after eating, those blood sugars go right across to the baby, and the baby cannot send that glucose back. So, thanks, Mom. We're having a lot of glucose over here. I'm just going to have to take that glucose and store it just like many other people store glucose, and it's fat. And it's only fat. We all store fat in sometimes very attractive places and sometimes not so attractive places. And in this case, the baby doesn't get a fat head, it gets a fat belly. And now after a child is born, and let's say it's born from a pregnancy with poor glucose control, it has accumulated all this fat and so forth, this baby will gradually, over 3 or 4 years, gradually sort of normalize, but won't completely get back to normal. So once you get fat inside your mother, there's a tendency to be fat for your life.
So then how do we treat it? So somebody's listening, maybe they're tuning in just because they got their abnormal glucose tolerance test and they're hearing about these bad news things that can happen. How do we fight back? How do we treat it?
So we're thinking about, it's all about mom's glucose, and so we put, that's the way it is with moms. We always make them responsible for everything, and so they're responsible for keeping the baby from getting fat, and that's by keeping those glucoses that we talked about that drive so much fatness into the baby, keeping those glucoses under control. And so in order to do that, we've got to start by measuring our glucoses and see what now with gestational diabetes, if the mother doesn't eat, her blood sugars are usually pretty normal. So we don't focus that much on between meal glucoses, even fasting glucoses in the morning, although we check them, most of the time those are normal. What happens is after the mother eats, the blood sugar surges higher than expected, and the pregnancy hormones mediate this. And now that we have a surge in glucose in the mother's blood, and it goes right across into the baby's blood. So we've got to have some way of reducing that post-meal surge in glucose. we can help by choosing foods properly. Try to stay out of those drive-in restaurants if we can, the fast food places, and making proper choices of food types and quantities and timing. All of those things work pretty well. And they actually make patients, by and large, feel better during their pregnancy when they're following a diet that doesn't have a whole lot of glucose basis to it. Having not so much carbohydrate, but having a fair, safe amount of fat and protein in it seems to work. But you won't know whether you're going to be overfeeding your baby and sending that glucose across unless you measure the blood sugars. And so measuring the blood sugars, especially after meals, because again, most women with gestational diabetes have pretty normal blood sugars when they're not eating. But the problem is they eat, they get a surge in their blood sugars, and that surge in blood sugars goes right across to the baby. So we're going to have her check her blood sugars after those meals and then try to choose foods that for her body and her food preferences work so the baby doesn't get too much glucose and therefore become too fat.
Once again, this is reminding me of many of our patients with, let's say, type 1 diabetes. It's always frustrating to keep that surge after eating down. And it depends on how many carbs you eat, lowish carbs, and spreading your calories and taking the right amount of insulin. But with gestational diabetes, I'd imagine, since you do have a growing baby inside, you got to be careful on how much you cut back the carbs. There's probably a certain amount of nutrients that's needed for, proper, fetal development. And you have that limitation to look at too.
Well, mothers worry about that. There was an interesting, very well-performed study at the end of World War II in the Low Countries, in the Netherlands and Belgium, when the Nazis pulled back into Germany for the final defense. They took all the food and they just basically created in the Low Countries a period of starvation that lasted 4 months. So we had pregnant women who were starved for the first 4 months of the pregnancy, for the middle 4 months of the pregnancy, and the end 4 months of the pregnancy. And guess what? Starvation did not harm the baby. And in fact, looking at how we're taking over our planet with humans, starvation does not harm the baby. So even though mothers are hungry and they feel like they need to eat, in fact, the having to eat is not really part of the deal.
All right, that's interesting. You're showing your age now, going back to the World War II. Tom, one last question to let Jeremy jump in. In terms of the therapies used to control the blood sugar, I know that there are oral medications that people with type 2 diabetes take, that sometimes they're allowed. Then, of course, there's insulin that typically is used to really ratchet down the blood sugars. What about metformin, sulfonylureas, things like that?
It's a big topic.
It still is?
It's a big topic. Quite a few randomized trials have been done with metformin, which is a very nice pill that you can take that can take the place of having to inject insulin. And so it's quite a popular thing. And most women tolerate it very well, and it will control, at least to a fair amount, control her blood sugars, her fasting blood sugars we can control, and with meals to some degree. And we like metformin. The problem is a lot of randomized trials have been done in Australia, and it showed that the takers versus the placebos of the metformin didn't have as fat of babies as the mothers who didn't take the metformin. They have fatter babies. But now everybody's worried that it's actually stunting growth. And there's some evidence, not proven, that the children who come out of a metformin-treated gestational diabetes compared to other treatments of gestational diabetes may have stunted growth and maybe some cardiac issues. So I'd say metformin is sort of a little up in the air. It's a great drug. I prescribe it for my patients, but I think a lot of specialists are very worried about metformin and really prefer to have the patient taking insulin, which we feel is not harmful.
So, what percent would you say off the top of your head of gestational diabetes can you get away with just diet treatment?
30%.
Okay, so then the majority are going to need some kind of medication.
Because remember, we call it the relentless escalator. The hormones that are coming from the placenta that are causing the diabetes, the hormone level that we have at 20 weeks, it takes 40 weeks to have a baby. The hormone level we have at 20 weeks is 1/3 the hormone level we have at the end of the pregnancy. So even though we've got a drug regimen that's working really good at 27 weeks, it's going to be more and more and more what I call the relentless escalator. So the idea that you can simply do it by diet or even get on a standard insulin dose and that'll be fine, no. You have to monitor your blood sugars and think through the dosing virtually every week.
So with that in mind, then when can you get a CGM for gestational diabetes? Is it anybody or do they have to be on insulin? What's the status of that?
Of course, it's very insurance dependent. So sometimes, depending on how we write the justification, we can get CGM for our gestational diabetic patients. But most, and definitely everybody who's on some government-funded, directly funded insurance, they have to do finger sticks.
Okay, so then it sounds like your algorithm is diet until that, I guess, quote unquote, fails, and then maybe metformin, but it seems like you're kind of leaning towards more that, insulin therapy. So I guess that's question one. And then question two would be, when people go on insulin, is it just mealtime because that's more the problem, or is it basal insulin also?
Yeah, and the answer to all those things is pretty much yes. The metformin helps. It lowers the amount of insulin that has to be taken, and it will prevent having to take nighttime insulin, maybe for the whole pregnancy. But daytime insulin, even though you take metformin in the morning, as we get later in the pregnancy, when the pregnancy hormones have gotten even higher, then having to add some insulin to it, I would say over half of women have to add insulin to their metformin dosage.
Tom, how aggressive are you in terms of goals? Fasting blood sugars, post-meal blood sugars, and do you now have goals for time and range?
Well, we definitely have goals for time and range, and we say more than 70% time and range is what we shoot for our overt diabetes. The monitoring that we have available for gestational diabetes doesn't allow that. We'll get there. I bet we will, but right now it doesn't allow that.
So, and because we've always talked about that the goals for blood sugar in pregnancy have been more aggressive than kind of people with what's called regular type 2, type 1. So what are the goals for fasting blood sugars during pregnancy?
So we want the fastings less than 90, and we'd prefer to see them down around 70. We don't go below 70. That's no fun. And people have symptoms below 70. So somewhere between 70 and 90 for the fastings. But I want to say, and I'll get to the postprandials in a second, but I want to say that some babies will acquire excessive fat with fasting blood sugars in the 80s. In their mom, because it's transferring more glucose, because it's not normal to have a fasting blood sugar of 80 when you're pregnant. And so that extra 10 points goes over to the baby, and for some kids, that'll make them fat. In terms of postprandial, we want those less than 140. And if we can keep them down, we don't want below 120. This is 1 hour after meal. So it's somewhere in that 120 to 140 range. And if we're consistently over 140, then we're going up.
So, I mean, that's tight, right? People with diabetes listening, including myself and Steve, like those are some tough goals to hit. And something that comes up to my mind when you say that you want the morning blood sugars to be 70, I feel like crap when my blood sugar is 70. So talk to us about hypoglycemia in pregnancy. Are they protected? Does it not exist? Like, what's going on there?
That's a great point. And hypoglycemia is the enemy. And it's an enemy because it shatters the patient's reliance and trusting of the treatment protocol. We cannot get down less than 70. We just don't. And so the 80s is good, but I'll tell you, for our patients who come to us with overt diabetes, and they have been used to their 90s with their fastings, which are going to make their baby very fat and at risk for stillbirth and some other things, within about 3-4 weeks, they're used to being in the 70s. Mm-hmm. So what you get used to, but the baby doesn't. The baby does not like fastings of 90, and it gets them fat.
What about A1C? We didn't mention that yet. I know you guys are zealots on get that A1C low, and I know it could be read off a little bit lower than normal because they're pregnant. So what kind of goals for A1C, just real briefly?
Well, again, we know that so in early we have a couple of different risks we're worried about. One of them is birth defects. So now we're talking about people who don't have gestational diabetes, but they have diabetes, pre-existing diabetes. And for those individuals, if their blood sugars are high in the first 13 weeks of pregnancy, that increases their problems of malformations. So we're going to want to get their fastings down in a range that'll be less than 80s for sure, to get them through that part. For the if you look at and as it has been looked at in randomized trials, trying to figure out what back to gestational diabetes, what makes the baby fat? And there's genetic factors that make the baby fat, but the biggest issue is the postprandial blood sugars. So that's why we look at the fastings and we want to control them, and that's why we have people with gestational diabetes taking metformin at night to keep those fastings under decent control. But the big relationship with fetal obesity and this big fat tummy we're talking about is in the postprandial period.
So clearly there's a focus on getting blood sugars down. But again, back to hypoglycemia, what if somebody does have a bad reaction? They're in the 40s or 50s. I'm sure that concerns mom, that she has to take glucose or maybe even glucagon or something. Is the baby protected from hypoglycemia or not? Is that a danger to the baby?
That's a great question. And as I say, the caregivers are, I think, at the greatest risk for a patient who has symptomatic hypoglycemia, because they're saying, I'm not going back to see those people. They're not taking good care of me. But I will tell you that when a mother gets hypoglycemic, the fetus defends itself and maintains its glucose level by recruiting stored glucose into their bloodstream. So it takes a really long period of maternal hypoglycemia where she's, passed out on the floor and nobody came around and stuff. When you get those babies and look at them, they're usually just fine.
Okay, well, that's good to hear.
Well, Tom, let's finish up talking about what happens after delivery. What happens to the blood sugars of the mother with GDM, and what happens for their risk of developing later on, and what could they do to prevent themselves from getting type 2 later on?
Great question. And so it's amazing that so the placenta is the source of the hormones that cause the insulin resistance and the whole diabetes syndrome for these patients. That placenta comes out, and if you monitor those hormone levels, which are sky high at the very moment of birth, by 24 hours later, actually 18 hours later, they're down below the table. They are low. They have returned completely to normal, and the diabetes is gone, which is great. However, if I have a genetic predisposition for insulin resistance, that's still going to be there. So that I'm going to probably get through, breastfeeding and all that stuff without needing. I mean, a few people have latent type 2 diabetes that we find at the end of the gestational diabetes episode. And that's a different group, and they have to be monitored and treated like type 2 diabetes. But the other individuals, what we tell them and what should be done is, okay, you're cured of your gestational diabetes, but you come from a background and a genetic situation where you may develop type 2 diabetes later on, so you need to do some stuff. And I think we all know what those things are. Getting the exercise, controlling your diet, and so forth. All those things help, and being aware and start treating so you don't end up finding out you have diabetes after you've got a whole bunch of organ dysfunction.
Well, I'm thinking as you're talking, is there any positives to this? That maybe I'm hopeful that there's data that people that do get GDM, if they do get type 2, maybe they're more educated, or like taking insulin might be easier for them. I don't know.
I hope so. Yeah. And I don't know of a paper for that. I think that's a good thing to study.
Yeah, I would think, Jeremy, that taking care of women who have diabetes during pregnancy, they always are the easiest and the more motivated because their baby's at risk. And if you can maintain that motivation after delivery, that's a win. And some women change their lifestyle for the better.
Oh, absolutely. I think for women with overt diabetes, going through a collaborative, skilled diabetes and pregnancy group is transformative. And now you've got to, it's like all things, if you can fall off the wagon and go away and, lose it. But you get such intense, not only treatment, but understanding of the things that are causing your blood sugars to be high or low or whatever, that patients leave the pregnancy with much more knowledge and capability. They do go back to their highly variable metabolic caregiving environment, and but for those patients who, for various reasons, just have sort of maintain a moderate level of control, they'll often come and see us preconceptionally and get the blood sugar down, get the hemoglobin A1C down before I get pregnant, just so I feel better about what we're doing. Because the birth defects do happen if you have type 2.
Well, I wanted to ask, starting to close, that, again, people might be tuning in, they just received this diagnosis or they're concerned about it. How hard or not is it to find somebody like you throughout the country? And I'm thinking when you started this 40 years ago, it was probably you and another guy you knew. And now hopefully this is becoming, more common.
Well, the good news is, let's say the bad news is that many endocrinologists didn't read the last chapter in their book that talks about pregnancy and the pancreas and so forth. They can't really to help somebody with the early lows and all the circadian rhythm changes that happen during pregnancy is different for them. OBGYNs, there's usually one or two questions on the written exam and sometimes an oral question on the oral exam, so they feel like they've got to study it a little bit. To become an OBGYN, virtually every training program has a diabetes and pregnancy program. Maybe not as full-on and crazy as the UC San Diego one, which does research and all these other sorts of things, but you're expected to know. But I'm going to get to the point here. Maternal fetal medicine. What is that, after all? Maternal fetal medicine is OBGYN plus 3 more years of studying a lot of things, but diabetes is a major thing that's done. And so in order to pass the exam and to practice maternal fetal medicine, you've got to understand diabetes and pregnancy. It's really a critically important thing. And so to the extent that MFMs are available and the patient can be referred to MFM co-management or even sole management. For type 1, it's probably sole management of MFM is pretty much the standard of care. Is it as available as it should be? Sorry, no.
All right, any closing thoughts, Steve? Or?
I would say, Tom, thank you so much. It's such an important area, and there's so much interest out there. on being healthy during pregnancy for women and their babies. And so nice of you to take time out of your day and educate us.
Yeah, I just say thanks. I learned a lot, and I think this is just such a relevant, great topic. We could really talk for another couple hours. I have more questions. But thanks so much, Tom. Really appreciate it. Thanks to all our listeners. Make sure to share this, like it, subscribe. I'll do those social media things for us. It really does matter. And we will see you or hear you on the next one. Take care.